Um, Good morning, everybody. This is our monthly ICOS seminar series, and this is the highlight of our seminar series. I want to take a minute to introduce Dr. Scott Ramsey. Dr. Ramsey is a general internist, but more than that, he's an economist. He's professor and director of the Hutchinson Institute for Cancer Outcomes Research. It's a multidisciplinary team who are devoted to cancer outcomes research. You must be familiar with something like that at our institute, the Institute for Cancer Outcomes. Dr. Ramsey is also a professor in the schools of medicine and pharmacy at the University of Washington. Dr. Ramsey, I didn't know that. Were you born and raised in Iowa?
I was born in Detroit, but I spent most of my early years in Iowa, yes.
Wonderful. So he received his BS from the University of Iowa, and I think that's when he fell in love with economics. That's where economics started becoming a big thing for you, but was double majoring in economics and general sciences. Who knew? MD at the University of Iowa College of Medicine, and then a PhD in health economics from Wharton School. After that, you decided Seattle would be a good place and moved over, did your internship and residency and fellowship and chief medical residency, and have stayed there ever since. Dr. Ramsey, besides being a brilliant human being, is also a very nice person. I got to know him because we were on the same JCO as associate editors team. And boy, when he spoke, everybody was quiet and listened and did not argue. He carries a mile-long list of grants that he has chaired. He's served as a PI for and also as a team member. He has over 400 publications, and then he is on a million different, very important boards and committees. He's the co-chair of the National Cancer Institute's Cancer Care Delivery Research Steering Committee, a co-chair of the SWOG's Cancer Care Delivery Committee, the past president of the International Society of Pharmacoeconomics and Outcomes Research, and he's also served on the National Academy of Sciences Cancer Policy Forum. So co-PI for the Coordination and Communications Center of the NCI's Cancer Screening Research Network. So with that introduction and the fact that we are so excited to hear from you, I will move this over to you, Dr. Ramsey.
Thanks so much, Smita. It's just a pleasure to be with you. I'm sorry I'm not there in person, but I am very excited to talk about the research that we've been doing in improving quality and reducing cost here in Washington State. And of course, I'm calling from Seattle, where we are the new Super Bowl champions and big parade happening in town, which is part of the reason I'm home today.
You had to get
So
that in, didn't you?
of course I did. We're it's when you live in Seattle, you learn to suffer for sports, so you got to take these wins and celebrate them. Anyway, so I'm going to be talking about a project that's really been going on since HiCor was founded 12 years ago, that was focused on really engaging every oncology provider in our state in a process of improving care and reducing costs for the cancer patients in our state. Um, and this is stuff I'm sure everybody on this call knows, which is that cancer care is very fragmented. It's disconnected across providers and insurers. Cancer costs continue to explode. We've done a lot of work in financial toxicity. It's highly prevalent among cancer patients and has severe consequences, including excess mortality for people who suffer a bankruptcy as a result of cancer diagnosis. And 12 years ago, I went to the director of our cancer center with the idea of starting an institute focused on attacking this problem. And my argument was that, we can produce all the great cancer therapies in the world, But if they're delivered inconsistently and they cause patients to go bankrupt or are unable to afford them, then our mission is compromised. So that's how HiCore started. And really, one of the first efforts was to try to bring multiple stakeholders together, not the usual suspects, but really a mix of people who are sometimes, antagonistic to each other, like insurers and doctors, to see if we could find shared solutions to improve care quality and reduce costs. And rather than put this at the end, I just want to give a shout out to the team at HiCore. We've got an amazing group that's been working on this problem, as I said, for 12 years. And we actually have a vision, and that is that every cancer patient gets quality care that meets their goals at a reasonable cost wherever they live. And this has been our call to action at our institute ever since its founding. So the way we attack this problem of improving care in our community, and we're focusing on Washington State, is through really three key pillars. One is to understand the priorities in our community. Researchers would often come up with their own priorities, but they may not match what priorities of people who are practicing is. So we have a steering committee that's, again, been meeting for 12 years that includes oncology providers, insurers, patients, and representatives from the state policy community in Washington State. And we meet twice a year. And we basically have listening sessions and we hear what are their issues, what are their challenges. And as much as possible, we use that to define our research agenda rather than us defining an agenda and then trying to impose it on them. We've turned their their priorities into something which I'll go into in more detail, which is a community cancer care report that shows quality metrics for areas that they felt we needed to measure and improve upon. And the third pillar of our engagement strategy is every year we have something called the Value in Cancer Care Summit, which happens in downtown Seattle. And we bring all these stakeholders together and we wrap that around a theme that is of interest and again has been informed directly by our stakeholder group. I'll get into that a little bit as well. So with that in mind, let me start to talk a little bit more about community engagement. So there are 28 practices, oncology practices in Washington State. Most are in the Puget Sound region in the west of the state where most of our population is. But we feel that the ones in eastern Washington, which is quite rural, are very important to support. So even though the bulk of the care is over here in Western Washington, we spend a lot of time talking with folks in the eastern part of the state because they have a very different set of constraints and needs. And we try to reflect that in our reports. As I mentioned, we have this thing called the Value in Cancer Care Summit, which is an annual meeting. It draws about 250 people that come from all over the state, including Eastern Washington. And it started in 2014. And I brought these folks together with a simple request, which was come up with 3 to 4 metrics that something we can measure at HiCore that would be meaningful to you as practitioners or patients or policymakers. Everyone had to agree they were meaningful, feasible to collect, and actionable. In other words, if we found problems with these metrics, we might be able to work on solutions. So they came up with 6 instead of 5, so that's okay. We worked on we worked on 6, but that meeting has happened ever since. And as I said, I'll show you the metrics because they're in some ways one of the most interesting parts of what we've been doing. But we've come back every year since that time, and we share data at our meetings about how how well people are doing with the metrics. But perhaps more importantly is we have the provider community and the patient community talk about these challenges. And in fact, with any metric system, if we report on the state, there's going to be people who do well, clinics that do well, and clinics that do less well. And we've kind of turned this on our head. We don't do a name and shame situation. we actually asked the clinics who were doing well to come up in front of this audience and tell us what they're doing at their clinics so they can share their practices with others. And through that, our goal is to improve care for everybody. So the second part, which I'll spend a little more time on, is our data repository. This is really a core element that we've built to support this network in terms of um, their understanding of how their care is relative to others. And I think it's important to note when we started this, um, we talked to a lot of providers. And what would you expect them to say if you asked them how they were doing relative to the community? They'd all say, they're kind of like Lake Wobegon. They're all above average, maybe even better than that. But what I quickly realized is not only did they not know how they're doing relative to others, they don't know how they're doing themselves because they don't really have an ability to collect data across all the different insurers they have and then collate it into something that makes sense. So we built this registry to address that problem. And it's got multiple data sources that are all linked at the patient level. So we have contracts with the two Blue Cross Blue Shield plans, Premera and Regence, Washington Medicaid, the Uniform Medical Plan, which is the state employees health plan, and Medicare. And we get healthcare claims from all of those data sources, and that's about 75% of the covered lives in Washington state. We link that with cancer registry records. We actually have two cancer registries in Washington state, one funded by NCI that covers the western part of the state, and then the Washington State Cancer Registry, which covers the eastern part of the state. And then because we have interest in financial toxicity, we've been linking these data with credit report data from TransUnion, Equifax, and actually directly from the Washington Bankruptcy Court. So we have credit report and bankruptcy records. Again, all of this is linked at the patient level, and we use this data to share information with our stakeholders. So what do we do with all this data? Well, we definitely do a lot of research, and some of the work that we've published in JCO and other places have reported out our metrics and the financial toxicity work. Um, but what I think we're most proud of as a group are these community cancer care reports. And there's a QR code that I hope you can scan or at least go to Fred Hutch Cancer Care Report on the web, and you're able to pull these down. So these are reports on cost and quality for every clinic in our state. And we've been producing these since 2018. And these are eagerly awaited in our state. When we publish these and we make the announcement, we've been told that clinics hold special meetings where they sit down and go through the data on their clinics relative to others. Um, and you may ask, well, was it okay to report information on the clinic level when knowing that some would do better or worse than others? We spent several years getting clinics ready for this report. And we spent time telling them that, first of all, as I said, this is not a name and shame. This is really to get everything better, that we would be there for them, that they could call us at any time and show, and if they had issues with our data, we would go deeply into their clinic's data. It was really important for us to build trust. We've also had supplements focused on underserved populations, specifically Medicaid, and I'll show you some data there. And we also have supplements that go deeply into the methodology of how we've done this. So the metrics that we did build, these are quality and cost measures, and we thought it was important to show both using best practices. So we didn't invent any new wheels here. We were using things that were already existing. As I mentioned, we wanted these metrics to reflect the priority areas by our stakeholders. And we told them we didn't want to have too many metrics because if you have 50 metrics, you're not going to improve on any of them. That's why we wanted, 5 ideally that we could focus on. The metrics are supported by evidence-based oncology guidelines, so all of these are consistent with what national organizations say are best practices. We do custom develop them sometimes with expert review when there were priorities from our stakeholders, but no metrics that were available from existing literature or organizations. And I have a paper here cited that you can look at that was published in JCO Practice describing it. So we rolled these out in a deliberate sequence, our metrics. We started just showing the results for the entire state, not for individual clinics. When we have the metrics, we originally shared the data first with the clinics and let them comment, and that all happened before they were publicly released. These metrics, we only report them over a 3-year time period to improve statistical reliability. And for each metric, we use something called hierarchical generalized linear models to adjust them for patient risk factors. And, every clinic says they're different, and I get that. And they want adjustment for their patient populations. And so that's how we do that. This is a standardized method that's used by CMS and others. Now, one of the biggest challenges is how do we present this in a way that clinics can actually understand and act on? So we spent a lot of time with stakeholders getting their feedback about how we would report these and how we would report people who are doing exceptionally well or less well. And we all decided that a 5% deviation from the average would be considered clinically relevant. These were the first metrics that we focused on: recommended cancer treatment, hospitalization or ED visits during initial chemotherapy after diagnosis, breast cancer tumor marker testing following treatment. Choosing wisely recommends against using breast cancer tumor markers for women with non-metastatic breast cancer. And then we had several measures focused on end-of-life care. So here's an example. I'm going to show several examples of how this is shown in our report. And again, I really encourage you to pull down any of these reports and see. So on the left-hand side is a list of, well, first of all, this is recommended treatment for breast, colorectal, and lung cancer. And so to get into this metric, patients had to receive appropriate therapy, NCCN recommended therapies within 90 days of diagnosis. And you can see in general that adherence in terms of getting recommended treatment was quite high, over 80% for really all the clinics. And the range wasn't very big. So that we plotted that, but of course we were also interested in cost. And on the right-hand side is how we plot costs. And I'll just take a minute to show you how this works. So we have the quality score on the left, in other words, adherence, and then the episode cost, which represents the episode of care that we're focusing on for the particular metric. So we have two dimensions. Are you above or below the quality mean for the state? If you're more than 5% above, you move out of that gray shaded area, or below 5%. And then on the axis, we have the mean episode cost per patient. And if you're right of that, you're more expensive than the average. And if you're left, you're less. And the individual dots or bubbles are the size of the patient populations in the individual clinics. So this gives everybody a very quick way to see how their practice is doing relative to others. You can see Fred Hutch comes out right at average on the quality score, maybe a touch higher, but quite a bit more expensive than other clinics. And I suppose it's worth mentioning that we aren't pulling any punches. The Fred Hutch doesn't always come out on top, and in fact, has some areas for improvement. So that was adherence to recommended treatments. Emergency department and hospital stays during chemotherapy. This is something we all try to avoid. It's a very difficult problem. What we found in our data, and perhaps you guys know this, but we didn't at the start, is that more than 50% of cancer patients in our state who start on systemic therapy end up in the ED or hospital within 90 days. So it's a huge problem, very burdensome on patients. We've done a lot of work looking at these ED visits and how it affects financial toxicity. But notice here the variability. Um, so, there's both, and also notice that there is a somewhat of a correlation between the clinics who have the best performance on the left upper axis there are the lower cost clinics, and those who have less good performance on the right side and below on the quality score are more expensive. And this is a theme that we saw um, over and over again, the relationship between quality and cost. It shows up, as you'll see in some of these other metrics. This is breast cancer tumor marker testing. Again, less is better. So the less tumor marker testing you do, the more you're in line with choosing wisely and ASCO recommendations. You can see there's a huge variation by clinic in terms of the use of tumor markers. Here, Swedish Medical Center, a third of their patients who, at least by guidelines, should not be getting tumor marker tests are. Northwest Medical Specialties is doing the best with barely 3% getting it. And again, notice the relationship between the quality score and the cost. If you're ordering less of these tests, your episode cost, which includes more than the test, it includes everything that wraps around those tests, is less. So end of life care, a little more complicated because we have four different component metrics looking at end of life care, whether an individual received chemotherapy in the last 14 days of life, less is better here. Multiple emergency department visits in the last 30 days of life, again, less is better. ICU stays in the last 30 days of life, and hospice care, at least 3 days prior to death. So you can see there is some variation, particularly in ICU stays, between these clinics, with some having very low use of ICU stays, whereas some half patients are in the ICU. So when you kind of put these all together, you find a pretty substantial variability in end of life care. So we build these four components into a composite. And again, this relationship shows up where clinics that are doing better on their quality score, those would be the purple clinics, the lighter purple clinics in the left upper, are just lower cost at the end of life versus those in the bright blue in the lower right. So that's lower quality and higher costs. And again, we're trying to highlight, places that are significantly different from the mean, so that if you're greater than or less than 5% from the mean quality score, the colors are different. And then you can see the costs there. As I mentioned, we also focused on underserved populations, specifically looking at Medicaid enrollees with cancer. And we rolled these data out at the state level. We did not report this at the clinic level for a couple of reasons. One is that the numbers get very small. Medicaid's, primarily a younger population. And so when you look at, for example, breast cancer, the numbers per clinic get so small that the statistical testing is problematic. Also, we worried a little bit about, clinics looking less good for Medicaid because this is a challenging population. So we only report this at the state level. But you can see that there are some disparities in care. So when we look at the metric for recommended cancer treatment, Medicaid patients are somewhat less likely, with 74.8% getting recommended treatment. Breast cancer, we focused on specifically, we had enough numbers there. Again, some disparity. And we also looked at somatic mutation testing based on cancer types for use of targeted therapy, and it was somewhat less also, again, for Medicare. When we look at hospitalization during chemotherapy, Medicaid patients are much more likely to end up with a hospital visit during the first 90 days of their therapy than similar patients in commercial plans. Breast cancer tumor marker actually less in Medicaid, so they did somewhat better. And then end of life care, interestingly, actually also, the same or better for Medicaid enrollees compared to commercial enrollees. Little less chemotherapy at the end of life, about the same for ED visits, fewer ICU stays, and more transfer into hospice. So the medical director of the state medical program, Medicaid program, was happy to see these numbers that Medicaid was doing better in this performance metric area. All right. So those were the metrics that we reported out for several years. And I didn't report some that were retired. We actually had some metrics where everyone was doing actually quite well over several years. And there's no sense focusing on those metrics. So we retired those and asked our group to give us some new things that they think are important to measure to reflect the evolution in cancer care over this time period. And I just thought I'd show you what we're focusing on now for our newer reports. Um, so we talked to the VCC steering committee, the Value in Cancer Care steering committee, and as I mentioned, this is mostly clinicians, but includes payers, patients, and researchers. Asked them what metrics they thought would be important to report on. We did talk to some disease-specific clinical experts, particularly at the Hutch. We talked to quality program leaders around the country, and we looked at what national metrics were out there because when we can, we try to reproduce those metrics because they are published everywhere, and you can see how you're doing compared to the rest of the country. Um, we wanted to remove the low variability and high adherent measures as I mentioned, and we continually update these measures if the guidelines change. And we added new disease areas as well. So one of the ones, I mentioned this, was somatic mutation testing for metastatic non-small cell lung and colorectal cancer. So, I mean, most of you, I'm sure, know that today for these cancers, a large number of patients are treated with targeted agents based on tumor variants. So we looked at this for these two. We rolled them up into a single metric because, again, the numbers got small for some of these. But you can see, and this was a bit of a surprise. Everyone was suspecting that it was going to be fairly poor adherence to mutation testing, but it actually turned out that almost all the practices were really testing most of their patients for these variants, and then of course treating with the targeted agents. So that was a good thing to say. I talked to a colleague in Tennessee, and he thought that the number would be more like 50 or 60% in his area. We also wanted to focus. We also heard loud and clear that germline testing was important for some cancers. So we focused on populations who met guidelines for germline testing. Breast cancer was a big one. So we looked at BRCA1 and 2 testing for people who met criteria, and that would include all men, women who have triple negative cancer, and anyone who was diagnosed with breast cancer under age 50. We looked at all ovarian patients to see whether they were tested. We looked at pancreatic adenocarcinoma patients, and then a specific subgroup of metastatic prostate cancer patients who are also recommended for testing. We looked 2 months prior through 20 months following, and for breast, as I mentioned, BRCA1 and 2, and then the other germline tests that were appropriate for the other cancers. And here things actually were surprising to me. So the rate of BRCA1 testing, just about 2/3 of breast cancer patients in Washington state who meet criteria for BRCA1 actually get BRCA1 testing. And I thought, if anything, this one would be quite high because this recommendation has been around for close to 20 years. But it is not. And as I'll show you, there's some significant disparities as well. Pancreatic, ovarian, and prostate were even worse. Ovarian somewhat better, again, I think reflecting the link with BRCA1 and 2 and ovarian cancer. But pancreatic and prostate really fell very low compared to what's recommended. And we realize that these are relatively new recommendations, but we would have thought that it would have been better. Again, looking at disparities, we found that the insurance type was highly associated with testing. So Medicaid enrollees and Medicare enrollees were less likely to get BRCA1 testing. Same is true for the others, with the exception of prostate, where everyone's doing so badly that there's not much variation. So it's one thing to measure. Um, what are we going to do with all this information, right? So we had always told our partners, particularly the clinics, that yes, we want to measure, we want to share best practices, and we want you to, feel supported by us. And, that's great. But some of these problems are very hard to solve in cancer care delivery. So, and there's no clear approach that we know that would be, able to improve, for example, reduce ED visits and hospital stays among people receiving systemic therapy. So we told them that we would like to begin an initiative to do cancer care delivery research in our state with them to try to improve performance. And we invited all clinics, but we're particularly interested in the clinics that were doing less well, whether they'd be interested in participating in experiments and new endeavors to try to reduce that. I should say, you might be thinking, well, you've been reporting on some of these. Are any of them getting better? Um, and I would say two areas have gotten better without any kind of intervention. One is tumor marker testing. You saw the numbers there, ranging from about 3% to 30%, with an average, I believe, around 20. When we first started reporting breast cancer tumor marker testing, more than half the patients in our state were getting tumor marker tests, at least against recommendations. We didn't do anything. We just simply reported them. We actually shared information with the clinics at their request about which doctors were ordering the most tumor marker tests. Um, and just through that, we started seeing reductions. And so what you saw is probably about a 25% reduction in tumor marking tests just by reporting out that information. So we haven't had any initiatives in that area. The other area that has shown some improvement is end of life care. And I don't know that I can credit our institute's work. I think COVID did a lot of shifting of patients to hospice care early and kept people out of ICUs. And that trend seemed to be holding after COVID hit. So has been a bit of a shift in less intensive therapy for people at the end of life and more hospice referral. But the others have pretty much stayed where they are, and that's where we wanted to focus time. We also feel strongly that we think Washington State cancer patients should be enrolled in research studies. There's a lot of data showing that only a minority of patients with cancer enroll in clinical trials. The numbers range from 5 to 10%. Now, those are typically therapeutic trials using investigational agents. Getting involved in those type of trials is a different type of situation for patients and for clinics to embark on. It can be very expensive for clinics to get themselves certified to a point where they can, support commercial drug treatment trials or even, NCI funded trials. So we wanted to focus on cancer care delivery because that's the problem we see. And that's where we thought would be a place where many clinics could enter with us and participate in these research because these are problems that they're telling us they have in delivering care, and we wanted to help them do better. So, recognize the challenges in doing any type of cancer care delivery research. For patients, it's a financial burden and a time burden potentially if they have to have extra visits. A lot of people, particularly in underserved populations, have distrust of the medical system and are uncertain about whether they want to be, quote, research subjects. And of course, even if they want to, most providers aren't offering research. We also recognize that for community oncology practices, which are very busy and stretched thin, that research is an administrative burden, it's a potential financial burden, and it may not be applicable to patients or their practice. I mean, we could spend a lot of time setting up a research study that ultimately a handful of patients a year are impacted at a clinic, and a clinic spends a lot of time setting themselves up, and not much happens. And we've seen that time and again with oncology treatment trials in the community. The Hutch, for several years, tried to bring in community partners. And frankly, when I looked at the burden that they imposed on those partners, I was surprised that anyone participated. And sure enough, over time, most of them dropped out. So we were aware of this, and we worked really hard to partner with the community providers for these cancer care delivery trials. But we really wanted to focus on improving care experiences and address challenges that, as I said, the patients and the providers said were issues that they struggle with. And we wanted to make it easy, almost invisible, to participate in a trial, both for the clinics and the patients. So those are things that we talked about a lot as a research group, but also with the clinics, because they came in saying, "Oh, you want to do research? I know what I'm going to have to do." And we had to tell them over and over again, "No, this is going to be different. We're going to work with you. We're going to try to make this as easy as possible." And sometimes that involves compromises. We don't get to do the ideal research study from our point of view, but we are doing something that the clinics view as important. And that, again, was our North Star. So how did we do this? We literally went to every clinic in the state, and we talked to them and asked them to identify challenges and priorities for care delivery. What are your pain points? How could we help you? And some of the things we simply couldn't help them with. I mean, you can imagine one that came up over and over again was prior authorization from insurers and how much burden that is. We are still working on that one, but we have to get the insurers to try some different approaches before we can implement something like that. But anyway, many other priorities. So we leveraged our expertise as cancer care delivery researchers and our infrastructure to develop studies that were really tailored to work within their workflow and their populations and to meet those goals that they had set for us. We also understand that these folks don't have time to write research grants, so it was our job to secure funding and to provide funding to them to offset the costs that they would incur when launching new studies that we were running, in their practices. So we started this 2 years ago, and I'm really pleased to say we have 6 studies now that are out in the community. They're all pilot studies. They're all small scale by design because we want to make sure, we want to work kinks out before we apply for, larger studies that would involve more clinics. So the first one was one that is focused on reducing ED visits. It's called Discover. We developed a smartphone app and had patients wear a Fitbit sensor. And we are simply tracking those people with their smartphone app. They every day they put in their symptoms and they wear their Fitbit. And we're collecting that data and we're simply looking at the relationship between the symptoms and the vitals as measured by the Fitbit and ED visits. And we're going to run that data through artificial intelligence and machine learning algorithms to see if we can predict when patients are getting into trouble before they end up in the ED and develop an alert system that we can send to clinics. We're also interested in whether patients who have significant health-related social needs are more likely to get into trouble early. As I showed the data for Medicaid, those folks are more likely to enter the ED during their treatment journey than folks with commercial insurance. So this is the start of what will probably be many years of research trying to reduce ED visits among that population. Veena Shankaran and I, as I mentioned, do a lot of work in financial toxicity. One of the things we found is that for most patients, it's a very small amount of money that they pay out of pocket. That is the difference between making it through with relatively intact or dipping into financial distress. So we've developed a randomized intervention of basically giving people money, unrestricted payments, following diagnosis to improve outcomes. Now you might ask, are the clinics actually interested in this? Do they understand that financial toxicity is a problem for their patients? And I have to say, over the last 5 years, I don't know if it's our work or just in general with the economy, but everyone is aware that folks are financially strapped and people are seeing patients not show up for follow-up appointments or saying that they can't afford to fill their prescriptions. So this has moved up much higher on community clinics' radar. So we have this one that we're employing or deploying. And on the right side are the partner clinics, and those are all community clinics that are working with us on these. Proactive is a study by Erin Gillespie. She's a radiation oncologist. Big problem for folks receiving breast cancer radiation is fatigue. So she's put together a virtual fitness program to help to address that issue. And she's piloted testing it in a couple of clinics. A lot of enthusiasm about that program. Megan Shen is a researcher focusing on end-of-life care. So she's developed a remote training intervention to help patients with advanced cancer and their caregivers with advanced care planning. Again, that's one that people recognize there's a problem, but it's just turned out that advanced care planning is very hard to implement in community clinics. So she's working on that problem. Hiba Khan's a oncologist specializing in prostate cancer care, and she saw the very low uptake of germline testing on prostate cancer patients. She talked to clinics and they said, we just don't have access to that type of testing. We don't have access to counselors. So she developed a program for remote germline counseling and testing. And that's been stood up at a couple of the community clinics. And then finally, an issue that was raised by many of our patients, the clinics also agreed, was social isolation and cancer loneliness. So Allison Cole, a quality of life researcher here at the Hutch, has developed an intervention to try to address that problem. And she's focusing on whether that will improve adherence to guideline concordant survivorship care. And that's also been launched. So some of this has been funded through Hutch internal funds that we were provided and some through pilot grants. But these are all stood up and starting in our community. Let's see here. That is the end of my presentation. I have finished with 15 minutes. Just closing comment. This has really been one of the most rewarding endeavors that I've done in our state. I mean, I love getting R01 grants. I love doing cancer care delivery research through SWOG, where I spend a lot of my time. But this has really been a dedicated effort to help cancer patients and cancer providers in our state get better care. It's been really embraced better than I could have possibly imagined by our community. As I said, these reports are really widely read. It's one of those things where we enter the room with this or enter a clinic, people are ready to talk to us. And that's just been so gratifying to take this research and these methodologies in a way that I think is meaningful to the people that we're focusing on. So it's been a great part of my career, and I'd love to take this to other states. So if this is something that Alabama thinks they can pull off, I am happy to come down and talk about it. All right, I will stop sharing and be happy to answer questions or comments.
Scott, thank you so very much. We would love to take you up on that offer. But there are a million questions, and I'm going to see if people are ready to ask. I mean, do you see all the hands clapping going up? That's everybody showing their enthusiasm for all that you've shared with us today. Anybody ready, or shall I? Oh, we have Joelle. Go on.
Thank you so much. That was a riveting talk. And I see several colleagues and friends who are also listening. I have a slant. I'm a prostate cancer oncologist, and I would agree that general uptake of germline's 10%. We're trying to make a dent in that. Just a question. When you're capturing the data, is it from orders or is it from results? I know just in Alabama, Medicaid coverage for germline testing is not as robust as commercial testing. Um, and so if I put an order in, but it's not approved, that's a different, to me, quality issue than if I don't think to order it. And I know this is nitpicking, but this is part of like the buy-in and how to encompass a robust quality measure. And thank you so much for sharing all your information.
Sure. Great question. And the way we identify people who get germline testing is through claims. So we don't know for those, for example, that one was ordered and not paid for, that wouldn't show up in our database. So this is simply the denominator is patients who meet the eligibility criteria. Numerator is we have a claim for germline testing. And that's how our number is. We are aware of the variability in insurance coverage, and part of getting this metric out there was to talk to insurers and say, hey, this is recommended. Um, you know, we need to improve this. I don't, to be frank, I don't know actually the state of, whether Primera or Medicaid or Regents covers germline testing. I believe the commercials do. I'm not aware with Medicaid whether they do. Um, but that's how our conversation gets started. And so, like I said, we don't focus on providers. We actually talk to the insurers as well. And so they're a little harder to talk to, but they do talk to us. So we're working on it.
And then just one additional question. Um, is the diagnostic part of the metastatic cancer, is that ICD-10 codes which then go into an insurer base, or is that from an EHR?
It's from our cancer registry. So we have that, we have detailed clinical pathological information from the registry. So we don't rely on claims for staging, for histopathology, for other things that you would need to know for eligibility.
Thank you. Bob Hollis says, really great presentation of real world work. Can you discuss funding sources for your overall studies?
Sure, sure. So we did get funding from the Fred Hutch itself to get this thing started, and it is not a trivial endeavor to support something like this. But we have a mix of funding sources. So there actually is a state funding mechanism called the Andy Hill Fund, which is a competitive grant application process that we've been successful with. It's tobacco settlement money that we've applied to successfully to do some of these projects. Our Value in Cancer Care Summit, we use a mix. We typically get industry, hospitals, and insurers to kick in small amounts of money. We kind of have a maximum that people can contribute, but we usually get a blend of places. Actually, some of the clinics that are in our network contribute money every year for supporting that program. And then, of course, we apply for R01 grants or PCORI grants, and we have a mix of support for that. As I said, though, most of the stuff we're doing on the research side, those are pilot studies. I will say one thing. The R01 cycle, you can tell a clinic, hey, we're going to start this study. And then, you start writing an R01 and it's 18 months before it gets going. By then they've moved on. We really try to find ways to get these things going quickly. So we're scrappy looking for little bits of money here and there. And that's one of the reasons we focus on pilot programs. We want to get these things up within 8 to 10 months after we've talked to the clinics. So we move as quickly as we possibly can.
Scott, I have several questions, and I want to start with the first, which is, are any of these oncology community practices formal affiliates of Fred Hutch?
Most of them, no. They have been affiliated in the past, but as I mentioned, that was through a clinical trials program that basically imploded because the burden on those clinics was so heavy in terms of all the credentialing the Hutch made them do. So I actually had to spend a lot of time just telling people, yes, I'm from the Hutch, but no, I'm not going to make you fill out 700 questions. One of the forms literally had 700 questions
Right.
um, to be part of our thing. We just want to hear what you say, what's the problem, and we will design something and work with you. But no, most of them are independent.
Okay. But if there were a place where there were a lot of affiliates, you'd have to probably deal with them in a different way when you were incorporating their data and analyzing it, I guess.
Well, we don't. So important to note that we don't have electronic health records from any of the clinics. We do have some from our own network. Frankly, it's cumbersome and difficult to use our EHR data. So
Mhm.
we have to design studies where the endpoints can be measured either through our data repository or through limited data collection. And we're very careful about additional data collection because of the burden
Mhm.
that it could potentially impose on patients or clinics. So, for the Discover study where we have the app and biosensor, the patients, they have to fill out the app and they have to wear the Fitbit, but the clinics don't have to do anything. And the patients actually kind of like that. They like filling out their symptoms. We've had very high adherence to that. But all that data bypasses the clinics and goes straight to us.
That's great. That's fantastic. I know Humaira is ready to ask a question, but I have one more that I want to sneak in. And that is that all the pilot studies that you showed us focused on the patients. Were there any system level intervenable issues that could have been addressed?
Well, oh, there are so many, but it's so hard to intervene on systems. And I'll tell you, Smita, one of the things that we've struggled with is when you deal with systems, you have to deal with leadership, and that's fine. But the churn in leadership in healthcare right now is so severe that it's very difficult to establish relationships and see a project through. So, for example, both Primera and Regents have had um, 5 medical directors in the last 10 years. Every 2 years, people switch out. It's hard to do anything with medical directors. One of the big hospitals we work with, Providence, has had so many changes in leadership that we can't even keep track of it anymore. It's, monthly there are people coming in and out. So that's been one of the biggest challenges for system level interventions.
Humaira?
Thank you so much, Dr. Ramsey and Dr. Bhatia, for honestly putting this seminar together, and absolutely echo your thoughts on. I think, like, to have leadership, and I feel like consistency. I'm fairly new to the survivorship section of things, and have been very blessed to join faculty at UAB right out of fellowship now from a couple of years ago. So I guess my question regarding like some of the hospitalization data that you shared for the Medicaid patients having higher numbers than regular insurance. One of the things that I've noticed for these particular patients is also that they come to me with more advanced cancers than others. They come to me with more comorbidities and uncontrolled issues than the other patients. So I guess when we are looking at hospitalization as a higher number? Are we looking at, yes, it's a marker because of the insurance, but I guess the insurance issue is coming with other things which are leading up to the delayed diagnosis or uncontrolled or other comorbidities. So I felt like it opens a can of worms, but it's important to address that. So curious to see what your thoughts are on that.
Yeah, you're so right in that folks with Medicaid have, typically more advanced disease, typically more comorbidity. Just for what it's worth, those data that we showed on disparity, we do adjust for those issues to the extent we can, and it's still higher. We know that Medicaid patients have much different set of health-related social needs, lack of home and social support. And actually, Smita, what you mentioned, which was, system level event, one of the things we want to do at a system level is collect health related social needs data on these patients, at the point of care. There's a lot of interest in it, but there's a lot of variability. What we would like to do for Medicaid patients specifically is identify the biggest health related social needs and see if acting on those would reduce ED visits. But we just haven't been able to crack the code of how to collect that information systematically. And some of these clinics that serve a lot of Medicaid patients, I'll just give you an example. And in Eastern Washington, three of the clinics we work with in these rural areas where patients have a lot of health-related social needs, they rely on locums oncologists. So oncologists are moving in and out of those clinics all the time. Some of them are practicing at three different practices that are hundreds of miles apart. So it's just really hard to work there and figure out how to set up a way to get an intervention going.
Thank you.
Can I ask a couple quick questions?
Yeah.
First of all, wonderful presentation. I've never had so many questions before, but I don't think I can squeeze them all in. So I'll ask a couple quick ones. So one is more of a specific one related to the interventions. I think if I remember correctly, some of them were run at multiple interventions were run in same clinics. I was just wondering, like the choice of certain clinics where there are logistical reasons or other reasons of where to run those pilots. And then my second kind of like more of a general high level question is related to whether in like when the choices of metrics that you are following, if there's any survivorship care metric there specific, and I recognizing that some of those clinics may not be providing some of those depending on the size of populations and whatnot. But I wonder if that's also was in consideration.
Yeah, well, regard to how clinics, choose to be part of our pilots. So we offer these up to, so we talk with the clinics, we try to find common themes. Then, we design the intervention, and often, we have to iterate on that intervention. A lot of the folks that are involved in those pilots are fairly junior. And it's a good experience for them because they design something that they think is perfect, and then they go to the clinics and they say, we can't really do all that stuff. So they have to dial it back and come up with something that actually can be implemented. So that goes through a process of iterations. And basically, so far, the clinics have just, we've relied on clinics to say, yeah, we'll do that. And we've been lucky, for all these interventions, we've had a certain number of clinics that have been willing and interested in stepping up. So it's been very organic how we pick those clinics. Your second question was related to, was it end of life care or?
It's survivorship care.
Survivorship care. Yeah. We do have a couple, we do have the goals of care intervention that we're working on. I'll be frank, it's not often as much of a priority for the community clinics, and so we've struggled with our research group who really wants to focus on survivorship care and the clinical practitioners that are saying, we just need to get people treated. We can't deal with this other stuff. So, a lot of these things, we have to find compromises. Well, can we do something remote while your patients are doing what they do? and that's how some of those remote interventions have come to be. At the end of the day, we want to say, look, when we had this intervention, it was actually easier for you. Patients showed up,
Mhm.
whatever. They filled their medicines. We're on a pilot phase. We don't have that answer yet.
Well, we're at the top of the hour, and we haven't lost anybody. Everybody's here on the screen. Nobody stepped away. I want to end by saying, Dr. Ramsey, if I could live another life, I would like to start working with you right during my fellowship. So it's been a joy. Absolutely. Thank you so much.
Well, thank you for giving me the opportunity. And like I said, we're eager to bring this to other places that are interested.
Yeah,
I know your group. You've got a great, great group there. So let's continue the conversation. And thanks again.
absolutely.
Thanks again to everyone for joining today.
Well, have a great and safe day. Don't go out for the parade.
Yeah, gonna work.
Yeah.
Take care. Bye bye.